Hello everybody, and welcome back to the Mayo Medscape video series. And today, we are going to be talking with our colleagues about the role of artificial intelligence in healthcare, specifically as it relates to cardiology, and identifying novel opportunities we are slowly identifying with work in this area. I am joined today by Dr. Francisco Lopez-Jimenez, professor of medicine at Mayo Clinic, Rochester, with an expertise in preventive cardiology, and his colleague, Zachi Attia, assistant professor of medicine, also at Mayo Clinic in Rochester, and a bioengineer by trade. They together comprise the leadership that are heading up the artificial intelligence efforts within innovation in the cardiovascular department at the Mayo Clinic. My name is Zachi Attia, and I'm also an assistant professor of medicine. So, Francisco, I've been hearing so many things that have been excellent about all the opportunities that exist of applying artificial intelligence to healthcare data. So when you look at the landscape of artificial intelligence and how it intersects with healthcare in general, what do you see as the future or the present of applying AI to cardiology and healthcare in general?
Thank you, sir. This is a very, very important question. I see the future being developed in three different areas, or three main areas. The first one is the optimization and automatization of the interpretation of echocardiograms, coronary angiograms, cardiac CTs, and other diagnostic modalities. And the second one is identifying people at risk. And I think that artificial intelligence has a big potential to identify those at risk for sudden cardiac death, those who might have a reinfarction, and those who might die from heart failure soon after they leave the hospital. And the third one will be the management of big data. As we know, big data is everywhere. So we need artificial intelligence to better handle those massive amounts of information that we get from wearable devices, from Holter monitors, etc., that will help us to better understand the underpinnings of cardiovascular disease.
Mm-hmm. So, Zachi, when we talk about artificial intelligence, if you had to explain it to a layperson, what is it exactly?
Thank you so much. That's a great question. AI, or artificial intelligence, is the ability of machines to mimic human intelligence. It enables them to automate the process of taking an ECG, for example, and give us the rhythm analysis. We also discovered that it can see patterns that human cannot see. Maybe it's the more interesting parts of AI. It can look at thousands or hundreds of thousands of ECG, look at the prognosis, and decide if the patient is going to have a disease. It does that just by looking at a lot of examples and the labels. We don't say what to look for, we don't define any specific features. We're starting completely unbiased and without a specific hypothesis except for the label we're looking for. And just by showing the neural network, for example, a lot of examples, it learned to find the patterns that are unique for each label.
Mm-hmm. So, if you had to think between the two of you, all the work you've done so far and that has been accomplished so far, I've read a lot of articles that have come out in this space. What do you think is the most promising or exciting discovery you've made applying AI to cardiac data?
Well, I will mention one, and I will let Zachi mention the other one. To me, the one that has been very exciting and innovative was this publication identifying people who have paroxysmal atrial fibrillation, but the electrocardiogram is in sinus rhythm. It really opens up a new era in cardiology, in particular in the analysis of electrocardiography, because it's finding a condition that we generally require an electrocardiogram that shows the atrial fibrillation to make the diagnosis. Mm-hmm. And now we figured out a way to identify those with paroxysmal atrial fibrillation with an electrocardiogram that might seem otherwise normal.
Zachi, your thoughts?
As Dr. Lopez mentioned, the interesting parts are looking at an ECG saying, well, it looks totally normal. The AI algorithm said something else, and the AI algorithm is the right one. Another example is the low ejection fraction detection. When we did the low ejection fraction detection, we divided patients by their current echocardiogram. We later on looked at patients that had a false positive, meaning an AI that says that they have heart failure or low ejection fraction, and normal echocardiogram, meaning the ejection fraction was actually above 50, not only 35 point. When we looked at their future echocardiograms, we noticed they have 6 times more risk of developing low ejection fraction in the future. Now, we don't think that the neural network was able to predict the future. We think it was able to locate subclinical features of the disease, so it can see something that humans can't see because it's below the surface. It basically helps us to define the term of previvors, patients that are going to have a disease, and maybe we can do something to prevent it instead of waiting for the disease to happen.
Mm-hmm. Wonderful. And Francisco, speaking from your clinical hat as a clinical cardiologist, what do you see as the potential and the potential hurdles as well of implementing these algorithms into general care?
Well, first of all, I think we have to be mindful that artificial intelligence might represent some challenges in terms of the validity of the data, the validity of the algorithms. We need to be sure that what we call artificial intelligence, it comes from good data, comes from data that can be reproducible, can be applicable to a variety of populations, not just a very, very specific group of people. The second thing is that the application of AI or artificial intelligence is challenging in the sense that we know that the application of technology doesn't happen just automatically, and we are used to all paradigms of medicine. So this is going to be or might become a slow process if we don't think forward in what is the best way to implement artificial intelligence. We also need to be careful not to assume that the implementation is going to be all successful. There is always unintended consequences of applying new technology. So we have to measure and evaluate every time we implement new algorithms to see if there is any unintended consequence in the application of that. An algorithm might be very good to diagnose a condition, but might have an extremely high rate of false positive results, and that will just make the healthcare explode into an exceedingly expensive healthcare systems if we are not careful implementing these step by step.
Yeah. I think you bring up a number of interesting points there, namely that the implementation science that underlies deployment of algorithms that are built out of big data is unique compared to where we've come from, right? Because where we've come from is we might create scoring systems, we might create guidelines, but still it was contingent upon the physician, the clinician, to make a decision based on entering the scoring system in or thinking of the guidelines as they apply to a patient. But now you're actually getting an automated read from a device saying you should think about this. What are your thoughts on, how do you think clinicians' behavior is going to change? Do you have any thoughts on that?
A good point, because I think the question is still up in the air. At the end of the day, there gotta be clinicians who will be ultimately responsible for what the machine is saying. So how can we reconcile this completely automatic system that is going to give you a diagnosis, and at the same time having a clinician who is responsible for that diagnosis? That's something that we have to define. Right now, for example, a car that is completely automatic, if the car has an accident, so who is responsible? Right now, you might say the company is responsible, but in medicine it's more complicated because there may be errors happening occasionally, and who is going to be responsible for that? So we have to really work on that, and how the clinician is going to still have the final word, which I think is going to be the case for many years to come. That no matter how automatic a system becomes, the clinician will have the final word to determine whether he or she thinks this diagnosis is present or not.
Okay. And Zachi, one of the major criticisms I hear sometimes of this kind of quote-unquote AI work, realizing AI is a broad field that includes many different machine learning and other techniques for data analysis, is the explainability. In other words, somebody tells us, okay, the ECG can tell us if you have a low ejection fraction or not, but why? And Do you think it's always going to be a black box, or do you think we'll get to a point where we will very readily be able to explain what these, obscure neural networks are actually seeing?
That's another great question. I think we will be able to open the black box and look and maybe peek into it and see what are the main features, what are the main drivers of the network, but we wouldn't really know exactly what it does. We will get hints, we will say, okay, I see that when this happens, the network decides this way or another, but I don't think it will ever be a fully explainable model. And I think it's actually a strong point for for these models, because the ability to explain also holds us back, because it only enables us to do what we can explain. If there's a very nonlinear, very gestalt-like feature that the network is seeing, and even a human being, an expert that can do the same task, wouldn't really know what it's seeing. He will just say, well, I see there's something wrong with it. I think we want to make sure we're not limiting our systems to only the very simple things we can explain. I do think that looking at big data, there's another issue that needs to be addressed, bias and the difference between different data distributions. So when we're testing a model, we want to make sure that we're testing it on a big variety of patients. We know that these neural networks and other AI models are very good in AI pattern recognition. If we have a pattern that we don't want it to recognize, there's still a chance it will recognize it. And we want to make sure that we can globalize and generalize the network and make sure it works for everyone. I think it's a key point that when you develop an AI model, when you validate it before using it, you want to make sure it actually works for the group you're planning.
And I think you brought up a great point, which is, when we talk about explainability, when we have an expert clinician, an expert cardiologist, leader in the field, walk into a room and say, oh, you're doing this wrong, it should be done this way, we accept it as gospel, even if they can't discreetly explain it in terms that will necessarily lead that person to be able to redundantly do it the same exact way that person was able to. They're actually giving their clinical gestalt, often based off of decades of experience. And it's like our expectations of the computer is very different than our expectations of the human. Because our expectation of the human is they don't necessarily need to be able to explain it as long as they get it right.
Yeah.
And it seems like we need to trend ourselves a little bit more towards that way of saying, okay, the data relationship is so complex that, if it's getting it right all the time, that's actually what matters. Yeah. Your thoughts, Francisco?
I completely agree. And indeed, I think the clinical decision making is a great example for that, but also the use of medications that we don't really understand. There are some medications that have been used for many years, and it took decades to understand the mechanism of action. But as long as those medications were proven to be effective, I don't think people were complaining about it. I mean, we have for example, the preventive effect of aspirin for colon cancer. We don't really understand how and why, but there are several studies showing that. So how can we stop using a preventive strategy just because we don't understand very well the way it works? We don't do that. And I don't think AI should be any different.
No, I totally agree. And I think, as we forge ahead into these activities, we need to marry the concepts of, well, we're replacing humans with the idea that we're actually augmenting the ability of humans to provide the care that we need. Because, as you're pointing out, otherwise, why invent new drugs? Why invent new techniques of doing the same type of work in a less invasive way? We do it because we think it'll provide better care, not because we want to replace a certain person or a certain group of people. We do it because care will improve and expand as we push forward.
Yeah.
Now, I feel like here we have a very unique relationship. Within our clinical innovation space, it's led by a data scientist and a clinical cardiologist. And just from your perspective, how do you envision that role? Do you envision healthcare evolving in the way of having data scientists embedded into the programs from the beginning? Or do you envision it as as calling upon individuals with data science expertise to come and do projects almost like we do our statisticians today. What's the unique element of bringing the data scientist versus the traditional model of statistics into play in our healthcare schema?
Well, what we have done here at Mayo Clinic is to have the engineers embedded into the clinical day-to-day activities, because that's really the best way for them to understand the needs, for us to explain them what we do, and together we can come up with better solutions than just limiting ourselves to what the clinician believes is important. I think engineers can come up with amazing ideas, and as it has been the case at Mayo, Zachi and others just come up with a recommendation or even a question: why do you do things this way? And the response many times is, well, because this is the way we have been doing this for years. And just challenging those paradigms is very important. Zachi, any words on that?
Yeah, so I think the main thing is that while we can outsource some of that work, I don't think it will allow us to create more innovative solutions as we go. A lot of our projects start in one point, and as we go along, for example, agent sex from ECG, when we did the ejection fraction model, we were looking at trying to find ways to improve it. When we didn't, we said, so how is it that agent sex don't improve it? And during our conversation, Francisco and I were talking to you actually, and thinking maybe the ECG can predict agent sex, and it worked. And I don't think that if we were disconnected and I would sit in a different office doing the technical part, you'll do the clinical part, we would ever get to these questions. And a lot of these questions started new projects in different fields. And I think the concept of working together side by side is much more thought-provoking and create a lot of new beginnings.
Yeah, and I think it brings up, it's been well known for a long time that to disrupt industries or disrupt ways we practice, which frankly I think all of us would agree in healthcare is necessary in this day and age, to achieve that disruptive innovation, you actually need to have a mindset that's anti-disciplinarian and anti-establishmentarian, such that you can actually bring novel insights that exist outside the existing paradigms of how you normally practice. And once you're entrenched, as you're pointing out, Francisco, in a situation, it can be extraordinarily difficult to bring in a new insight or a new idea that would actually go against the very grain of how you've been trained to practice and how you have been practicing, unless you're forced to do so by someone like Zachi coming in and saying this could be done a different way or thought of differently.
Yeah, and you being an electrophysiologist, you have seen this for the last 20 years or so, how the work between the clinician and the engineers developing new technology to solve a lot of medical problems, pacemakers, ICDs, and a number of other things, truly require the people outside the medical expertise to essentially get into the clinical field and see what the needs are, and working together with the clinician to develop what we have right now.
Mm-hmm.
I also think it's beneficial for the engineer as well. I think my questions or my ideas now are very different than what I would ask 5 years ago when I just arrived. I think working with physicians is much easier to understand what are we trying to solve, how to make a change on the patient prognosis, and looking for projects that are worth doing. Eventually we have a limited bandwidth to all of us, and we want to focus on things that can get to patient and actually help them.
Great. And I think it's one of the biggest things I see personally as a potential with artificial intelligence isn't really for healthcare, but for delivering health. Because right now we're all talking about patients, and the fact is most of the human population aren't patients. Most of the human population have never been a patient and might never be a patient until they get truly sick and are close to death. And I think when we start talking about how do we cost effectively scale our expertise and our abilities to everybody to deliver health as opposed to delivering healthcare, artificial intelligence techniques might actually allow us to achieve that, where frankly no number of physicians could accommodate, even if you spread them out worldwide and spent several trillions and trillions of dollars to create. But going forward, in terms of final thoughts. So, Zachi, where do you see this kind of as the next? What do you see the next steps in these relationships and building AI and incrementally adding AI into the healthcare system?
I think that today, as we can get ECGs from our phones, from our watches, from a digital stethoscope, we have much more control on how we monitor our health. And the use of AI can help us do that and only send us to the physicians when we actually need it or before we actually need it. But I think it can reduce anxiety, it can help you scale healthcare, it can especially help in rural areas where it's harder to see a physician, go to other countries when there's one physician over 10,000 people. I think it will be much more significant there. And just by scaling everything to the cloud, you just send your ECG, for example, or your echocardiogram. It's done first analysis by a machine, and only if needed, it goes to an actual human being. I think it can help reduce the amount of patients.
Mm-hmm. And Francisco, any final thoughts?
Well, one common concern around is whether AI is going to take our jobs. And I don't think that should be really a concern. Many years ago, I remember when CT scanners and MRIs came and became standard of practice, the idea was that neurologists would be out of work because most of the work they used to do was just trying to make the clinical diagnosis. Well, we know now that neurologists can do amazing things thanks to the technology that MRIs and CT scans brought. So I think AI is going to help us to be better doctors, to practice better medicine, more individualized, more precise medicine every day. And it's going to perhaps give us more time to spend face-to-face with the patient, particularly as AI might help us to navigate the electronic medical system in a smarter way, in a more efficient way that will definitely impact the quality of life of providers and the health of our patients.
So in other words, AI might let us become human again?
Perhaps.
It's a great summary, I think.
All right.
It's a great point.
So thank you, Francisco. Thank you, Zachi, for joining us. And thank you, everybody else, for joining us on the Heart.org Medscape Cardiology.